the next in our case series of basilar thrombus. This case is a tough one, which is why I want to go over it. And we can start with the non-contrast images. And if we just start with our axial here, we'll see this is our basilar. And here it's a little bit more challenging compared to other cases. Maybe it's a little dense here. However, it's hard. And if we go to the coronal, I have to admit, I don't really think it's the most impressive hyperdense basilar sign. So this is something that may not really be readily apparent on the non-contrast. This patient obviously had symptoms, and this was a code stroke that was done given their neurologic symptoms. So we do have a CTA. However, I do want to impress upon you how important it is to window appropriately so that you can make the findings. So here's our basilar, and as we come up, we'll just see a little caliber change right there. And that is the non-occlusive thrombus. So as you go through, we're at the tip now, there's our PCA, but we'll just go over that again. It's subtle. Not all basilar thrombus is going to be completely occlusive. This one is not. It's a very small, short segment, but it is still important to make the diagnosis. And here, I would say it's maybe a little bit more obvious on these axial images, but let's take a look at the coronal. And again, it's really important that you window correctly because it's just this little narrowing here, that caliber change. A little bit more obvious on the axial, I think, especially with this projection, because it's not completely occlusive, you can get faked out. But especially if you're not windowing and you maybe have a window like this, everything can look like it's fine and you may not think anything of it. But as you kind of change your window, you will notice that there is a little filling defect there. Now, in the case of this patient, they were outside the interventional treatment window, but we do have an MRI that does help us realize that, even though this is a small segment basilar thrombus, it can still be devastating because we have a brainstem infarct here, and the ADC shows that this is a real acute infarct with reduced diffusion. And then we have scattered infarcts in the right cerebellum of various ages. The coronal diffusion will help us here as well too, and you can see that brainstem infarct. It's quite serious, and that's acute. And the flare, just to go through, we'll see there's varying ages of different flare signal. We still don't have too much flare signal for that brainstem infarct, but the point is it's infarcted, and the patient will have a permanent neurodeficit as a result. So this is a scary case, subtle, no hyperdense vessel on the non-con, but that's not 100%. And you really, in this case, want to look at that axial very closely to notice that filling defect. And again, not all basilar thrombus is going to be the most obvious. It's not all going to be completely occlusive, but it can still be consequential. So very important to try to make this finding and a really good case to learn from.